Okay students, so now we are starting with the question number 3, that is basically clinical case studies. Now this question number 3 in your exam, second prof exam, is usually clinical case studies. So let's see some questions from the past year. The first question is, a 45-year-old female presented in the OPD with complaint of headache on left side, nausea, vomiting since morning. She was having difficulty in looking towards light. So the history is suggestive of migraine, and she is also having photophobia, vomiting. Probable diagnosis of mild migraine is made. Now write the drugs required for treatment of this patient with reasons. Okay, now in this case, how you are going to answer the question. So the first question they're asking, write the drugs name. So in acute migraine, then you are supposed to write NSAIDs, that in acute migraine we use NSAIDs. Write some details about NSAIDs, like ibuprofen, etc. They inhibit COX and reduce the prostaglandins, reduce the pain, right? Then there is paracetamol, which also produces centrally acting analgesia, right? Then we have triptans. So triptans are ones like sumatriptan. So sumatriptan, they are basically 5-HT, 1B, 1D agonist, right? And they cause vasoconstriction and they inhibit the migraine. Then you will give some antiemetics. You will write about antiemetics. Antiemetics like domperidone is given for relief from the vomiting. And then you have CGRP antagonist, because migraine is said to be a disease of inflammation. So CGRP antagonists are said to inhibit the inflammation, and so they are effective in the migraine. Okay, then write the names, mechanism of action and adverse effect of triptans. Now triptans, so यहाँ पे आप detail लिखोगे, like they are 5-HT, 1B, 1D agonist. They cause cranial vasoconstriction and then they also reduce the neurogenic inflammation, right? Adverse effects of triptans, they can cause coronary spasm, so they should be avoided in coronary artery disease patients, and they can cause chest tightness, right? So these are the side effects. Enumerate drugs used for prophylaxis. Now in prophylaxis we use, the first drug of choice is propranolol, right? Then we have tricyclic antidepressant. Then another drug, that is flunarizine, right? Then we have CGRP antagonist, and we also have anticonvulsants. The space is less, so anticonvulsants like valproate and also topinamate. So this is the answer that you are supposed to write in this question. Okay. Next question is, a 57-year-old male diagnosed with a new case of smear positive pulmonary tuberculosis presents with sclera, icterus, tea-colored urine, vomiting, dyspnea, swollen stomach, legs, cough and loss of appetite. The patient has experienced after taking ATT for 15 days. Right, lab investigation suggests deranged liver function test. He is diagnosed with ATT-induced hepatitis. So this is the diagnosis. Now classify ATT drugs. So in classification you have to write first line drugs, that is isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin. And the second line drugs also, that is ethionamide, cycloserine, PAS, kanamycin, then capreomycin, then fluoroquinolones. Then write down the drug treatment for smear positive TB. So in this, now the correct answer is that you have to 2 months of HRZE plus 4 months of HR. That is the WHO new guidelines. Next is enlist hepatotoxic AKTs. So hepatotoxic drugs mein we have isoniazid is hepatotoxic, rifampicin is hepatotoxic, and pyrazinamide. Describe modified ATT regime in ATT-induced hepatitis case. So now in this we have to first stop the hepatotoxic drugs. So drug-induced hepatitis is stop hepatotoxic drugs. Then you have to start with the second line drugs. Plus you can add streptomycin or ethambutol can continue. You can add levoflox also. Reintroduce them once. Reintroduce them slowly, one by one, right? Now next question, what is the recently approved standard treatment for MDR-TB? Now recently approved standard treatment is basically bedaquiline based all oral regimen. So these are the new drug treatments which are approved for, specifically, see, the question is for MDR-TB. So this is the answer, bedaquiline based oral regimen is the drug approved treatment. Next question, a 60-year-old hypertensive patient comes to the emergency with bradycardia, low BP and a history of beta blocker use. Right, now so patient is already on beta blockers. Now he is presenting with bradycardia and low BP. So this is suggestive of beta blocker toxicity. Now toxicity, so what could be the possible cause? Possible cause is beta blocker toxicity, right? Next, name 2 probable drugs which are responsible. So it can be propranolol and it can also be metoprolol. What is the antidote for beta blocker overdose? Antidote for beta blocker overdose is IV glucagon. Okay, now how do beta blockers decrease the blood pressure? So beta blockers decrease the blood pressure by their beta-1 blocking action, that is by acting on the beta-1 receptors on heart. They reduce the cardiac output. Then they also reduce the renin secretion, so they reduce the RAS excess, and they also reduce the central sympathetic outflow. And so all these things together, they result in fall in BP. What precautions should be taken while prescribing them in a diabetic patient? Now beta blockers basically because they are reducing the sympathetic outflow, so they can reduce the or what they do is they mask the hypoglycemia symptoms. They mask the adrenergic or sympathetic symptoms which are associated with hypoglycemia. So it can result in something called as dangerous hypoglycemia. So this is a precaution need to be taken in patients who are taking beta blockers and who are diabetic. A 28-year-old female presents with complaints of chronic dry cough, facial puffiness and frothy urine. Blood pressure is 150/90. Urine shows proteinuria. Diagnosed with early diabetic retinopathy. She is started on enalapril. So this This looks like a case of diabetic nephropathy, right? And enalapril is started. Now classify ACE inhibitors. So ACE inhibitors ka classification mein you can write captopril, then enalapril, then lisinopril, right? Ramipril. These are the drugs. Then what is the mechanism of action of enalapril? Mechanism of action of enalapril is that ACE inhibitor hai. So ACE inhibitor basically will inhibit the ACE enzyme, which will reduce the angiotensin 2 and which will reduce the vasoconstriction and salt and water retention. Plus it also reduces the aldosterone, right? What are the common adverse effects of enalapril? The first common adverse effect is dry cough, then hyperkalemia. Another thing that is associated with it is angioedema. If a patient develops persistent dry cough, then which alternative drug can be given? Then you can start or switch the patient to ARBs, that is angiotensin receptor blocker. You have to write the names and the mechanism of the drugs here. Enumerate therapeutic uses of enalapril. So uses of enalapril mein we have hypertension, then we have diabetic nephropathy, then we have CHF, post-MI patients, and it can also be used in proteinuria. Next question. A 45-year-old man visited the OPD with history of pain in epigastrium, right hypochondrium, revealed that the pain radiates to the back and is relieved on taking food. He takes meals twice a day. So on examination, there is tenderness in the epigastrium. So this basically case is suggestive of peptic ulcer, right? Now what could be the probable diagnosis? So diagnosis is peptic ulcer. What investigation will you suggest? Now investigation we can suggest is upper GI endoscopy, right? That is what we can suggest to the students. What treatment would you suggest? Write in detail. Now treatment here is PPI plus antibiotics for 14 days. So this will take care of the also any other instructions that you would like to give. Now any other instructions may the instruction will be like avoid NSAIDs, then avoid spicy food, take regular meals, and avoid cigarette smoking. So that will also help. Any other, mention the side effects of the drugs that you are giving him. So PPIs usually they cause headache, then they also cause diarrhea, and vitamin B12 deficiency. Antibiotics that we are giving may cause GI upset or rash, right? Coming to the next question. A 50-year-old male complains of chest pain on exertion, relieved on rest. Blood pressure is 130/90. Rest, physical examination normal. ECG findings normal. Diagnosed as classical angina pectoris. Now write the drug of choice for acute chest pain in this patient with its mechanism of action and adverse effect. So drug of choice for acute pain is nitroglycerine. And how does it act? It causes release of NO, which causes dilatation, and it also reduces the preload and thus reduces the chest pain. Enumerate the drugs that can be used for chronic prophylaxis of angina pectoris. So drugs that can be used in prophylaxis are beta blockers and CCBs, then long-acting nitrates, then we have ranolazine and trimetazidine. So these are the drugs which can be used for chronic prophylaxis. Explain why beta blocker and CCB should not be given in combination. Now beta blockers also reduce the heart rate. So beta blockers reduce heart rate. CCBs can also reduce the cardiac contractility, the drugs which are acting specifically on the heart, like verapamil. So then there is a risk of severe bradycardia or heart block. So that is why CCBs are not combined with beta blockers. Next question. A 40-year-old woman comes to the hospital with complaints of urinary urgency, burning, micturition, low-grade fever. She has similar episodes during last 3-4 years. And physical examination, there's tenderness in suprapubic region, body temperature is 150 degree. So there are no facilities for any test. Now what could be a probable diagnosis? So probable diagnosis in this case is recurrent UTI, and outline the course of treatment. The course of treatment in this case, since we don't have any facilities for tests, so empirical treatment may we can give nitrofurantoin 100 milligram BD for 5 days, and also good hydration to be kept. Prophylaxis that you would suggest is behavioral changes can be given, and hydration to be kept proper. Next question. A 30-year-old female has seizures beginning with the loss of consciousness followed by stiffening of all limbs and rhythmic jerking of all the limbs. So she is diagnosed as a case of generalized tonic-clonic seizure. So that is GTCS epilepsy. Now classify the anti-epileptic drugs. So classification of anti-epileptic drug is now huge. So we start with drugs which cause sodium channel blockers. Then we have drugs which cause potassium channel openers. Then we have drugs which reduce the calcium channels or block the calcium channels. Then drugs which increase the GABA, and drugs which decrease the excitatory, like NMDA antagonist. So this is like in this way you have to classify the drugs. Which anti-epileptic medication would be useful for the management of the above case? Now in GTCS, the drug of choice is valproate, and other alternatives that can be given are lamotrigine and levotiracetam. Explain the pharmacological basis of treatment. Pharmacological basis of treatment may by reducing the sodium channels or blocking the sodium channels, we are basically keeping the cells in prolonged inactivated state. Prolonged inactivation state is there so that the electrical signals are not able to pass through. And by increasing the GABA is a CNS depressant, so the main objective of increasing the GABA is to depress the CNS, decrease the neuronal excitability. So that is the main aim of all the anti-epileptic treatment. Mention the adverse effect of these drugs. So adverse effects में valproate के बारे में आप लिख सकते हैं that it is hepatotoxic, and then it is not to be given contraindicated in pregnancy. Then it causes alopecia, weight gain, all these symptoms, adverse effects are there of valproate. Next question, a 40-year-old man presents with episodes of breathlessness, wheezing. On spirometry, FEV1 is 55% of predicted value. He is diagnosed as moderate asthma. So write the options available for treatment with therapeutic basis. Now, moderate asthma. In asthma, we have to take the GINA guidelines. So moderate asthma and the GINA guidelines say give inhalational corticosteroids, that is inhalational corticosteroids plus LABA, that is long-acting beta agonist. Right? In case of acute attack, relievers ke roop mein you can use SABA, that is short-acting beta agonist. What is their mechanism of action? Corticosteroids will reduce the inflammation, and LABA will cause bronchodilation by causing beta agonism. What is the probable route of administration of these drugs? They are given by inhalational route. Inhalational route se diye jate hain so that they have a high local effect and minimal systemic toxicity. Okay. Next question, a 50-year-old male patient is admitted in emergency department with anxiety, restlessness, lacrimation, sweating, piloerection, insomnia, tremors, diarrhea, increased BP, mydriasis, intense drug craving. History taking revealed him to be a chronic opioid addict belonging to Western Rajasthan. What is the diagnosis and emergency treatment of this patient? So the diagnosis in this patient is opioid withdrawal. So these symptoms are suggestive of opioid withdrawal syndrome. Now, what is the emergency treatment? So in emergency treatment of opioid withdrawal, first of all, you have to give hydration. Then you can give clonidine. You can give antiemetics. Okay, antiemetics. Don't give opioid antagonist directly. Okay, antagonist is not to be given here. Further advise the patient for de-addiction. For de-addiction, then the treatment that is used is buprenorphine, which is basically a partial agonist of morphine, or we use methadone maintenance therapy. So it helps in reducing the withdrawal symptoms of morphine. 58-year-old man presents with complaints of tightness over middle part of the chest, felt episodically relieved within 5 to 10 minutes of rest. Investigation ye to again the case is of angina. Okay, stable angina. This is classic stable angina with dyslipidemia as the lipid profile is deranged. So this is the probable diagnosis. What immediate medication can you give to relieve the condition? Immediate medication is NTG, that can be given as 0.5 milligrams sublingual. So it will cause vasodilatation and relieve the preload. What other drugs can be prescribed to be taken on a regular basis? On a regular basis, then we will prescribe him the long-acting nitrates, which will cause vasodilatation and relieve the angina symptoms. We can give beta blockers, and since the lipid profile is deranged, so we also need to start him on statins, and we can also start on antiplatelet, that is low dose aspirin. Okay, what non-pharmacological advice? Non-pharmacological advice is weight loss and diet control and smoking cessation and exercise. Okay, so these are the options that dietary lifestyle control that we can tell him. And a 50-year-old man visited medicine OPD, difficulty in breathing, wheezing, cough on examination, pulse rate is this much, blood pressure, respiratory rate, auscultation, reduced breath sounds, spirometry 51, FEV1 was 70% predicted. So this looks like a case of COPD. Okay, now classify the drug that can be given. So in this we can give SABA, we can give LABA, and we can also give anticholinergics like ipratropium bromide or tiotropium bromide, right? And then we can give inhalational corticosteroids. Pharmacological basis of treatment. So in asthma, there are two targets to reduce the inflammation, that is done by corticosteroids and mast cell stabilizers and leukotriene receptor antagonist. And the second thing is to increase the bronchodilation. So that is done by SABA, that is beta agonist, LABA, long-acting beta agonist, and anticholinergics. So these drugs they cause. Another drug is methylxanthine, that is theophylline. So these are the drugs and the pharmacological basis. Two common side effects of above drugs. Now side effects of SABA ke side effects, remember 3 T's. It is tremors, tachycardia, and prolongation of QT interval. T-wave inversion, so that is called as arrhythmias. It can precipitate arrhythmias. Anticholinergics, they cause dry mouth. Remember the side effects of anticholinergics: dry mouth, constipation, urinary retention, and mydriasis. These are 4 typical side effects of anticholinergics. Common investigations required to monitor the treatment. You can monitor the treatment by doing spirometry and chest x-ray, and check the oxygen saturation repeatedly. The last question in this series, a 50-year-old male with type 2 diabetes mellitus, blood sugar 150 milligram, blood pressure is raised, urine albumin is there, so mild albuminuria, serum albumin this one, normal, serum creatinine. So the diagnosis here, this condition diagnosis, we can say that it is diabetic nephropathy with hypertension. Which antihypertensive drug is safely used in renal problem? In renal diseases, ACE inhibitors can be used, ARBs can be used. Mechanism of action, we have earlier discussed, they reduce the angiotensin II action and they reduce the glomerular pressure and renal protection. What is the treatment required? Treatment in this case is a tight glycemic control, right? Then BP control and low protein diet, since he is also having kidney damage. What are the 2 serious adverse effects of the above drug? Now ACE inhibitors, they cause hyperkalemia and they cause angioedema. These are the 2 serious side effects. What questions asked for physical examination and investigations required for treatment monitoring? So check the blood pressure, check creatinine from time to time, potassium and urine protein, and ask to do the fundoscopy also. So with this we finish the clinical case study questions from past year questions. Now students, coming to the question number 4 of the theory question paper. Now the question number 4 is basically short notes, right? So here we have actually, I have collected the past year questions, short notes like microsomal enzyme induction, and with each short note I have given you the definition, effect, examples, clinical concern, or something related to that particular short note in short, which will help you in writing an answer. So what you have to do is basically you can download this PDF. I'll be attaching this in the description, and you download this PDF and you read it one day before the exam, because it is going to help you in remembering certain things about that particular question and will help you in answering that particular question. Even if you don't remember much, but this much also if you remember, you can write at least an answer that will fetch you marks. So this is a list of around 70 short notes from past year questions, and just download the PDF and download this and you can just study it before your exams, and it is going to help you with the study. So there are around 70 MCQ short notes. Okay. Now coming to question number 5 in the theory paper, as we all know that it is explain why or explain briefly questions. So here these are past year questions, around 30 questions are there, and with each question I have written a small explanation. So this will help you in writing your answer. Apart from that, I have done a full video in which I have given around 50 questions which are explained why. So these questions will help you in writing those answers, like indomethacin, why it is used in pediatric closure, colchicine in gout, montulocust in asthma, omeprazole in peptic ulcer, artemisinin in malaria. So all these like explain why this is used in this disease, why particular disease area is happening, why acetylcholine cannot be used as pharmacological agent, halothane, why it is contraindicated in pheochromocytoma, then treatment of different diseases, thyroid storm, why dopamine is used in cardiogenic shock, why N-acetylcysteine in paracetamol poisoning, why benservazide is combined with levodopa. So these are around how many? More than 30. There are 46 questions in total, and you can go through them very fast, super fast revision karke, and you can write something in the exam.